Welcome to the Mostly PT podcast. I'm Brent Bulmer.
I'm Alex Bretzman.
Today's episode is sponsored by butter. I can't believe it's butter.
Can't believe it's not butter.
Yeah, but it is butter.
You gonna taste test that one?
No, do you want to?
No, it's straight fat.
I think my external rotation got worse.
Did it? Mine's not bad.
It's because I'm wearing jeans. All right. First off, thank you to all the subscribers. You know, we just reached 200 last week, so we really appreciate the support you guys have had for us.
203, I think, is the exact number.
Really?
Yep.
Wow.
That's great. If you would have said we would have had 200 subscribers while starting this thing, I would have told you you're crazy.
You're crazy.
You're crazier.
Thank you.
There's 200
Thank
people
you, brother.
that found this entertaining enough where they're like, yep, I'm going to subscribe to this channel. Kind of crazy, man.
Why are you checking your watch?
Get notifications.
Okay. First off, would you rather?
Would you rather?
Would you rather? What's the question?
Would you rather be able to rewind time or fast forward time? So let's say situation, you either can go back a certain amount of time or go forward a certain amount of time, but once you make that decision, you can't change it. So either you have the ability to go back as far as you want.
Well, that you
Or go
kind of
forward.
just explained why you would pick rewind.
No.
Because you'd be able to change it.
No, you can't change it.
Then what would you? Okay, so
I would fast forward because I think like there's an hour of stuff that like class for something.
Yeah.
Like you're like, this is I do not need to be, like the only reason I here is because attendance is mandatory and I'm not going to use any of this. Skip forward an hour.
And then you wouldn't get that information, or would it be like a thing where you skip an hour and whatever happens,
Whatever
but then
happens,
you have that knowledge.
Your
in
brain's
head.
on autopilot, but like
Okay.
you still take the information, but
Okay. What if you like are a bad kid in class, and in an hour,
Well,
you,
okay,
you
let's
fast
go-
forward, and now all of a sudden you're in the principal's office.
let's go like you don't remember. So like traffic, you're stuck in traffic. You're like, man, it's gonna take 20 minutes to get through this. Just boom. Like you're obviously not gonna die.
You
it's a
could,
simple.
though.
Okay, it's a simple.
That's-
Would you rather be able to go forward in time or back?
I would go backwards.
I would go forward.
And I'm gonna say why, but then you're gonna say, "Oh, you can't do that."
Why?
But
Why? Why would you rather go? Why would you rather have a rewind button rather than fast?
I mean, the obvious answer is to fix mistakes that you've made.
you're getting in. We're getting into time travel again. I mean,
It's a form of time travel. So
I guess, yeah. But okay,
If I can rewind, right? If I can rewind, I should be able to change things, because if you fast forward, things are changing. So therefore, I should be able to change things, which would also be a thing where you would argue why not to do that, because if you change it, then you could. I mean,
okay.
think about if we're talking about the universe here. If you change what's going on, you might have to pay for the consequences. But if someone says that to me, you know what? I'm just gonna rewind again. Rewind and rewind.
Our would you rather questions always turn into would you rather time travel or not? Because we went like back 5 years to talk to yourself or go forward to talk
Would
to
you
yourself.
rather have a hot tub time machine, or would you rather be able to whatever you need to use to get
The
fast forward?
fast forward button is not a skip. So when you're like, do I retain anything or whatever? Like if you're sitting in class,
You should be able.
you just go really really fast. So like
But you
an
should
hour
be able to
turns
retain
into
that.
an hour turns into 5 minutes. It's not blink and you're an hour ahead.
Then what's the stipulation for rewinding then?
You can. What do you mean? What's the stipulation? You can rewind and you just redo it over.
Okay. Oh, okay. All right. So if you're picking that, let's say you fast forward a bunch of through your whole life, right?
But you can't.
Do you age?
Because that's the thing that we had.
You would age.
Here's the thing, because we had originally
You
was
should
rewind or pause. Because like the stipulation about pausing is while you have stopped time, you are still living and time is still occurring to you, and you would continue to age. So if you pause time for 10 years, by the time time would resume, you would be 10 years older, and everyone else would be the same age because you stopped time. So you would rewind. I guess it would take. So if you'd be 20 minutes younger, and fast forward, you'd be 20 minutes older. It would have the same effect on your body as it would if you're chronologically, and it wouldn't have changed the effect of the immediate future.
So we're saying you would age.
Yes, and you would reverse age. So technically,
so
if you want to go back to
the question is, would you, if you're part of the question, if you're gonna skip through things, right? You're basically just saying, hey, your lifespan shorter. It's gonna feel way shorter, depending on how many times you're skipping through it.
20 minutes, sure, it's gonna add up over time.
Let's say you skip through class 100 times an hour. That's 100 hours gone.
You can only use it once.
You could have used 100 hours to make friendships with your classmates, and it's gone. That just sounds like a bad deal to me.
What if it was limited to like 5 minutes only?
That wasn't part of it.
Well, this is this thing we always run into when we talk about this.
Well, the thing is, we have a question, but we're trying to figure out what the question is.
Exactly.
That's the problem.
That's the problem, is because we always debate it much where we try to change the question to make it suitable for what we pick. That's our problem.
That's what an argument is.
Right.
Let us know in the comments.
Would you rather be able to rewind or be
That's
able
a
to
tough
fast forward?
one.
I think it's rewind. Or no, I don't think it's rewind. I think it's fast forward. I think it's more suitable.
Speaking of rewind, let's rewind back to last night. Jake Paul fight. Thoughts?
I thought it was kind of sad and a little bit embarrassing.
For who?
Tyson. I think it was a lose-lose situation for Jake Paul. Obviously, they both got a bag. I think they both paid $20 million a piece. But if you're Jake Paul, you beat him, obviously. Okay, you just beat a 58-year-old retired washed boxer. Mike Tyson, obviously one of the GOATs, probably top 5. I don't know enough about boxing. Probably Muhammad Ali is probably the GOAT, but Tyson's probably up there on the Mount Rushmore. But, okay, if you beat him, which you did, you beat a 58-year-old. If you lose, you just lost to a 58-year-old.
Yeah.
I think it
was almost like, do you think Tyson was trying?
I think it was scripted.
Yeah.
I think he tried for the first round and then think he got gassed.
But Jake Paul even admitted, he's like, I didn't really want to knock him out because I don't want to hurt someone that doesn't need to be hurt.
I think there was a slap at the weigh-ins. Did you see that?
Yeah.
I think that was scripted. Totally think that was scripted.
I mean, it was a real slap.
Yeah, and it was to boost the ratings.
I'd slap someone to boost ratings.
The real problem was the Netflix live stream was absolutely garbage. And
that's why I do not have Netflix.
Netflix should not be able to do live sports again. And they have Christmas Day NFL games with the Ravens and the Chiefs playing at 2 different time slots. If that happens again and America can't watch the Ravens or the Chiefs, Netflix might go bankrupt.
I'd just go on Sports Surge and pirate the show.
Yeah, just do it illegally. Yeah, there's your way.
Also, another thing. What do you think was going on with Mike's knee?
What do you mean?
I don't know. He had a knee brace. He obviously has a hurt knee.
Well, he's 58 years old, probably for stability. The biting thing was weird.
Yeah, he said he has a biting fixation.
He has a biting fixation? I thought that was like...
No, but the announcer was like, I've seen him do that in many other fights. So maybe that's what he normally does.
I thought
a waste of energy on my
I thought it was more of like a nervous tick kind of thing.
Where he's like in so much pain that he's biting himself.
Or like, I don't know what I'm doing. I'm just going to revert back to what I feel is normal, and that's...
It's like a baby like sucking on their thumb.
Totally.
It's like comfort.
Yeah. That's what I thought it was. I don't know. Entertaining, I guess.
Not really.
It wasn't the greatest fight I've ever watched, and I'm not a huge boxing guy.
Do you know you could have bet on that fight?
Yeah.
It was minus 200 odds on Jake Paul.
Yeah, he was the favorite for sure. I don't know why you'd ever bet on a scripted event.
Bite?
Well, we were talking about biting. Why would you ever bet on a scripted event? If you were going to bet, you should have bet on Jake Paul, because I think there was no case scenario.
People probably didn't know it was scripted. That's the point of having a script, for people not to know that.
That was as close to WWE as boxing gets.
Boxing is kind of becoming WWE.
They signed a contract for it to do like the 8-minute or the 8 rounds for 2 minutes. I bet guarantee in the contract there was like a no knockout clause where no one can swing hard enough to knock a guy out. Tyson was gassed, and he looked like, I mean, in shape for a 58-year-old, fine, but there was no way that after round 1 or like probably after round 2, they were like, yeah, Mike's got this. No.
Yeah.
If that fight wasn't going to end in the first round, which it never was because they weren't going to allow that to happen, then there was no way Tyson was going to win. If Tyson didn't walk in the ring and knock him out in 30 seconds, then he had no chance.
Do you think right now, without any training, you'd be able to beat Mike Tyson?
No.
You could just run around.
We kind of had this, I was talking this conversation. You wouldn't be scared if someone of the same combat level, So you have zero combat
I
training.
got some combat training.
You've never boxed or fought in an organized sport matter.
See how fast that was?
Yeah, that was lightning quick. Anyways, would you be nervous with a 58-year-old of the same level of martial arts skills as you fighting them?
No.
Exactly. That's what it was. They're both trained boxers. And there's a 30...
But Jake Paul has 4 years of training.
He's got 31 years of age on him and a 7-inch reach. They did weigh the same. Jake Paul called out Conor McGregor on Twitter the other day, or today actually.
Yeah, of course he's going to call him out. Have you seen Conor McGregor?
Yeah, he's on crack.
He's a little bit obese. Unless he's on crack, then he lost weight.
He's on coke. He just
probably shouldn't say that.
He just
that
admitted
word.
in court that he was on cocaine, so that was crazy.
Well, probably shouldn't say drugs on there.
Well, it's pop culture.
Don't do drugs, kids.
Don't do drugs. Don't do drugs.
I think I don't know. I mean, if I had like 6 months of training, I could definitely beat your.
If you think you and I went at the same, let's say we went to the same weight at like 182.
If I increased my stamina, yes, I wouldn't have to increase.
And we had 6 months to prepare, who would win in a fight between you and I?
I think I would win.
I think it's the same thing where if you don't beat me in the first 2 rounds, you would win by knockout. But if we went the distance, I think I would beat you.
If there wasn't a ref, I'd beat you because like I don't care if
No. This is a organized boxing match. It's not street fighting. It's put the gloves on, referee, we're gonna fight. You know what?
How would you beat me?
I think I can last longer than you. Like I just explained it. If you're not gonna knock me out in round 1 or round 2, I'm going to win off decision.
I mean, I got some stamina. Once I get my aerobic system up, like after 15, 20 minutes.
Yeah, you need to call your cardiovascular system and figure it out. Whatever. For 100,000 subscribers, Brant and I are going to organize box and live stream it on this
I
channel.
would do it for at 500 to be honest.
No, we're not. That wouldn't give us 6 months to prepare.
It'd be fun to do.
We'll
I
box.
could wrestle right now.
We could wrestle. I got weight on you right now, though. We're not in the same weight class.
10 pounds.
We'll box at 100,000 subscribers.
Yeah. Give us 15 years.
And we'll televise it on YouTube.
Yeah, live. Okay, live stream.
There you
All
go.
right. Well, we probably should talk about some PT stuff since we're the mostly PT pod.
After we've talked about, I don't know, probably 12 minutes of nothing. Sure, yeah. Let's talk about a little bit of physical therapy. What the viewers come to look for. I don't think anyone click subscribe not being like our friend or like, I want to know more about physical therapy. I'm going to subscribe to this channel. There's not a single subscriber that's like
You'd have to skip to the last 10 minutes to actually learn something about
Maybe,
it.
you know what? One episode, we should flip it where we put the PT stuff in the front.
Yeah, that's a good
Probably should
idea.
do that more.
Yeah, that's a good idea.
You know, yeah.
Yeah, this is a perfect example. It's like, hey, let's rewind. I could have rewinded back. Yeah.
Yeah, that was self-reflection.
It was.
That was a group
I'm always
self-reflection.
self-reflecting.
I'm always learning.
Speaking of self-reflecting,
Adapting.
I'm going to reflect back on Dominic's question. Thank you, Dominic.
Dominic?
He put a question he commented, can we hear more about ankle mobility?
Ankle mobility.
What do you know about ankle mobility?
I know that I have bad ankle mobility.
I do as well.
I have very limited dorsiflexion. With our nice white Nike socks that people seem to be obsessed with.
What do you would you rather be severely limited in plantar flexion or dorsiflexion?
Dorsiflexion, 100%.
Yeah, because that's
You
what
need
we're-
plantar flexion
that's
to
what we
walk.
are, yeah,
You need 20 degrees to go upstairs.
yeah, without compensating.
Right. You
guess.
could probably make by with shaking a little bit. Probably make by with 0 to 5 degrees of dorsiflexion. That's basically what I have. But if you couldn't plantar flex your foot, you'd be in a lot of. You couldn't run.
Okay, let's say someone has severely limited plantar flexion. What are you gonna do? How are you gonna improve their mobility?
We're gonna work on the gastroc. We're gonna
Gastroc?
We're
What about the
we're gonna
soleus?
strengthen. We're gonna strengthen the calf,
Okay.
the triceps surae, if you will.
Okay.
To work on their mobility, I think just moving them through all planes of motion, dorsiflexion, plantar flexion, inversion, eversion. I think that'd be good for it.
Any special exercises that you like to use?
Probably just calf raises, probably the biggest one. Seated.
Like stretching or anything?
Stretching, I'd probably just stretch the gastroc. But that really wouldn't, or you could stretch the TA on front, because if that's what they're limited, then that's probably what's tight.
Do you ever do mobilizations with movement?
Mobilization with movement. What do you mean by that?
Like mobilization while having the patient move. So like, or okay, example.
Nice.
Let's say I'm limited in dorsiflexion. Okay, you attach a band to the back of their ankle, and it's basically pulling forward while they move into the range. So it's kind of doing some kind of mobilization.
So it's giving
and they're
them,
moving.
It's
I.e.
giving them
mobilization with movement.
at the anterior glide, basically, while they're doing a movement.
I mean, I don't. Yeah, technically, if we're going off biomechanics, you would have the band pulling posteriorly,
right?
To improve dorsiflexion biomechanically. But like, I would rather have the band in the back, giving them more of a stretch. Assisting them into the motion.
Like almost an active assisted range of motion.
Yeah, active assisted mobilization with movement.
AAROM.
Mobilization with movement actually sounds way cooler.
Fair. That's probably
More cool.
It does sound
I don't
cooler
know.
than AAROM.
AAROM.
That's kind of.
I just say AAROM.
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 AAROM. Shout out, Dad. That's my dad's name. He's not watching.
Do you ever do ankle mobs?
I haven't seen a ton of ankle patients.
Me neither.
I really don't.
But let's say like it doesn't even have to be someone that has ankle pain or ankle instability, whatever you want to call it. If someone has problems with squatting, or if you want to work on, throughout the chain, you could work on ankles.
I think that's fair. If a patient is coming to you or someone is like, hey, I have poor ankle mobility and it's affecting me while squatting, then I think you squat and you find ways in which they were compensating, and then you work through more not a pain-free movement, but a movement that they can get enough ankle mobility and still be able to perform the functional activity that they're trying to do.
Yeah.
That's what I had to do. When I squat and when I hack squat, I can't exactly put my feet all the way down to activate my quads because I can't dorsiflex that much, so my heels start to come off the mat or the platform. So I have to slide my feet a little bit more forward to be able to get full range of motion without my heels coming off. So I wish I had better dorsiflexion. I probably could, I don't know, maybe adjust it 5 degrees if I worked on it a lot, but at that point it really doesn't matter that much. But if it's someone's extremely limited, then I think, like per se on a hack squat, starting their feet higher and then slowly working them more down as they're doing it.
Yeah.
Like over a course of period of time, and their ankle's probably going to adjust to be able to fit that range of motion. Bottom line,
I mean, I had something to say, but
go ahead. Yeah,
I think also working on ankle mobility can be good, especially for, let's say someone has extreme hip pain, right? You can move their ankle, you can do ankle exercises, ankle mobility exercises without, really hurting the hip or making their hip pain worse, especially for severe, high irritable.
That's fair,
right?
Like
it's just like
yeah, I like that.
Working on some other joint that's doesn't hurt as much, but also working on something to improve their function.
Have you seen like the people that I don't know if they're necessarily chiropractors or doctors, maybe podiatrists? They're like, all of pain in the body, like even low back pain, starts with your ankles.
Yeah,
I start with your feet, like because they're out of line or because you have limited dorsiflexion or plantar flexion, that's causing you to compensate in ways that's making your back or your hips or your knees hurt. Like I don't know if I don't believe in that.
I don't believe in that. I think working on ankle mobility can help up the chain, but you can never say, hey, your ankles are messed up, that's why you have hip pain.
I think, because someone has like referred pain in their hip, they're like, oh, it's because your ankles.
It definitely could. It could be playing a huge factor, but I'd say even just saying that is just not.
I don't. Yeah, it's not a good patient education thing to be like, oh yeah, you have hip pain because of the way that you walk, because your ankle can't dorsiflex 5 more degrees than normal.
No, you basically you kind of say the same thing, just in a different way. Like, hey, we're gonna work on your ankles to help your hip. But that's like kind of the opposite of saying, oh,
your hips.
You have hip pain.
Your ankles, but
You have hip pain because your ankles. Let's work on the ankles.
Yeah. Well, okay. So, not talking necessarily about stability. Well, I guess that kind of stability or limited range of motion. People that have chronic ankle sprains. I know you've had issues with chronic ankle. I've never had. I mean, I've rolled an ankle before, but it's like it hurts for 3 minutes and it kind of goes away, and then I'm ready to go again. I've never severely turned an ankle where I'm like out for a limited amount of weeks in like high school sports. I've never done that. But people are prone to it because I don't know if it's necessarily an instability thing or they have poor range of motion. I think it just happened really bad one time and then they're just more prone to reoccurring injuries.
Yeah.
So people that I have really bad ankles and I can't do organized sports, or I can't do something without a brace because I'm going to roll my ankle again. I think it's just because the ligaments that are already damaged are kind of already lax there, and they're just more prone to movement, and then that's how you roll your ankle.
I've had chronic ankle sprains, and my ankles don't feel lax. When you do
Not necessarily lax, but repeated trauma to an area.
Yeah.
More likely for it to happen.
Yeah. Thoughts on let's talk about something else that we normally don't talk about. Surgery.
Surgery. When is surgery? When is surgery
appropriate?
Do you want to break it down by
like example, someone with should we do hip or knee?
We can do both. They're not the same thing, but I think they're
let's do hip. Let's say someone has hip pain, they come in. When is it appropriate to recommend surgery?
I think it is appropriate to recommend surgery, if the patient is in a lot of pain, or they have limited mobility, or something that is restricting their life that is directly being caused by their hip, something that is wrong with their hip. Precursor to that, if that is actually the problem that's going on, I think they need to try movement, and they need to try resisted exercise first to either strengthen the joint or promote a better healthy range of motion before they actually go through with the hip surgery. But we know as physical therapist students and as a PT that hip replacements have a very, very high successful rate and satisfaction rate. They're one of the most successful orthopedic surgeries that you can get that is pretty much low risk, and you're going to have the best outcomes with it.
Why do you think that is?
More with the anterior lateral approach than the posterior lateral, because you're not cutting through the glute anymore. But if I'm going to give my educated guess, I think it's because with people that really need them, let's say they have really bad arthritis or osteoarthritis, and they're basically their hip socket is degenerated. When you give them basically a new hip joint that's made out of, it's not made out of plastic, it's steel and some other element or whatever, that moves really, really well, and then you can strengthen the muscles around that, and they basically have a new hip. Yeah. That's why I think people like it the most.
I think it's one of the better outcomes. I mean, you could say it's probably the most researched,
orthopedic surgery.
Yeah. Also, my thought would be, after hip surgery, you have to move the hip if you want to walk.
Right.
If after hip surgery, I can't do. I literally have to move my hip to walk.
Yeah.
So they're forced to walk.
Mm-hmm.
One, and we know movement is good. Motion's lotion.
Motion is lotion, baby.
So, but knee, right? After knee surgery, I can do this without moving my knee. I don't have to move my knee, but I can still walk. Other ankle surgery, I don't have to move my ankle. Hip, I have to.
You have to.
Unless you had crutches or something.
For a better gait.
But still, you would.
It's just the way biomechanically that we're made. You have to have hip flexion through the gait cycle, or you can't lift your leg.
That's
or walk
just my
in the desired way.
I think you're just forced to move. Therefore, outcomes are better.
That's fair.
I don't know if that's based on research, but
people that only get knee surgery or knee replacements and hip replacements just because they're in pain and they are completely sedentary, and that's why their hip hurts, and they're like, I'm just going to get a hip surgery or whatever, and it's going to decrease my pain, and I'm not really worried about continuing to move or complete functional activities throughout my life. That's where I think it's negative, and that's what I think surgeons do it anyway, because it's the American healthcare system and people want money.
Well, I mean, if you think about it, if I'm putting myself in their shoes, I'm a surgeon, I'm probably gonna go towards surgery. Just like physical. If we're physical therapists and we're always recommending physical therapy, that's a bias.
Technically, yeah, it is. But so that's human nature at one point.
Yeah,
if you're an accountant, you're like, I want to do your taxes. You should 100% come to my private firm to look at it so I can do
taxes. I mean, you gotta be
anything in life. Teachers are going to recommend education to students because that is their job. I mean, it's the same.
It's the same. Exactly.
So
So there's I feel like it's not wrong to recommend surgery for someone who wants surgery.
It's not. It's not. I totally agree. I don't think it's wrong.
Somewhat appropriate.
Yeah. Right. I don't think surgeons are in the wrong for recommending their surgery because that's what they do.
Yeah.
I think the best surgeons do the preoperative things first. Be like, okay, I think you're compatible and probably need a hip replacement in your future. Let's try this first. I think that's the best type of surgeon.
So then, do you think the best physical therapists are the ones that can recognize when surgery is appropriate, even though they could be working with them for longer?
I think, yeah, the best ones
I
are
would
saying
agree.
this patient's not necessarily not getting better, but their symptoms aren't improving, and we've been able to increase their range of motion by 5 to 10 degrees, and it really hasn't done anything. They're still in a lot of pain. They still can't play with their grandkids. They can't go for their walks like they used to. Okay, I think you're still appropriate to get hip surgery, and I think that's okay because we just talked about it. That has a high success rate, so therapists are more likely to be like, yeah, I think it's cool if you get your hip replaced, and then it's a win-win for them because if they're already seeing them prior to their hip surgery, they're probably going to come see us after their hip surgery, and we're going to treat them anyway.
Yeah.
It's
Ultimately, if the patient wants surgery, I think giving them education on the benefits and the risks.
Yeah.
And then saying, hey, if you want surgery, you know what? That you have that, like, you can decide if you want surgery. If you want surgery, okay, we go that route. These are the benefits, these are the drawbacks. And once you say that and they still want surgery or they don't want surgery, I feel like you can sit with yourself and say, hey, I let them know, I gave them this information, and I don't have to feel bad about not doing that.
Ultimately, it's the patient's call because they have free will, and then obviously the surgeon has to approve it. But yeah, I think if someone's like, I'm dead set on I'm going to have a hip replacement, they're going to have a hip replacement. I think that's fine.
What's your thoughts on precautions? Protocols. After, let's say hip.
I came up with an analogy today that I was actually kind of proud of, and I think it's actually a good way to teach patients or give them an educational standpoint, is that post-surgical precautions are like the speed limit. When you're driving down a road, you can still move. You can still move throughout ways that you find comfortable and are not limiting you. But you can't move so much where you break that line of the speed limit, and that's where injuries can occur. Then this is where I think can really hammer it home. Let's say the speed limit's 60 on the road you're driving on. You can drive 60 or you can drive 80. You're not necessarily going to get into a crash, but you're more likely to. You're more likely for bad things to happen the faster you go. So I think that's a really good thing that I might actually have
That's
to
pretty
use
good.
that.
And physical therapy is basically a Tesla. They're guiding them in the car.
Sure.
So,
But I think you could also change it. You could be like, okay, first week post-op, you're in town, speed limit's 30. 4 week post-op, speed limit's 55.
yeah.
You're finally out, 75. You're out on the interstate, it's 80, you're out on the interstate once you're 6, 7, 8 weeks out. And then,
That's a pretty good analogy.
And then there's really no reason to go any faster than 80 miles an hour, especially at the age that the person's probably getting it. Be like, you could drive 100 miles an hour. There's really no reason to. You could do all the things that through a pain-free movement and to achieve your functional goals at 80 miles an hour.
Do you think there's any benefit of not always following precautions as a therapist or as a patient?
I think there's some benefit. I think there's also some risk with it.
Yeah, well, that's what we're talking about right now.
The benefit of not following surgery, not necessarily following them to a T, is not having your patient be fearful of movement.
Yeah.
Because that's what I got way caught up on, and we're learning about the hip and going through like treating in class. Like, okay, you have a hip. Your patient just had a hip surgery 2 weeks ago or 2 days ago. You have to get him up and mobilize him. I was so caught up on, okay, we got to make sure that we don't get past 90 degrees of flexion. We can't do this. We can't do that. We can't do that. It's when you worry about it so much. I think myself that I learned that it affected me and then it affected the patient.
Yeah.
And not necessarily, I haven't seen a patient that's a hip surgery and I was worried about it. It was a simulation in class with another student, obviously. But I think if it was a real clinical situation, if I'm worried about him moving, they're going to be worried about him moving, and that's where the bad outcomes start.
Yeah. I think the best way, I don't want to necessarily go against the surgeon, right? But I also think sometimes the precautions, the protocols might be more stingy than what you really need.
I agree.
Or the patient might take it to where, I think a big thing too is they have precautions or they have precautions. It's like, oh, you can't lift something more than 10 pounds. They never get told you can lift more than 10 pounds after their rehab. So then they go throughout their whole entire life and never lift anything 10 pounds.
And then
that's terrible.
So now they don't bend over. Now they're losing movement by doing that, and then they just decrease their range of motion throughout the course of their life. I totally agree with that. I think the speed limit analogy is like rock solid.
Yeah, I like
That's pretty good. I might have to start using that.
It worked on me.
Yeah, if it works on brand, it's got to
Just
work
on
on
speed.
a 64-year-old who just got her hip replaced.
Also, just talking about it, I think let's say you don't know, you have a surgery, right? Patient come in, they had a surgery that you don't really know too much about.
Okay.
I mean, you should have information prior, or like you're unsure of. I think this is kind of opposite of what I normally use. Like, use pain as a guide. You know, if something's extremely painful, especially right after surgery, first 5 weeks, it's probably a good idea to, you know what, temporarily stay away from that.
Moving in a pain-free movement is probably always the best case scenario for your patient, that either surgery or not, I think.
So if you go shoulder, right, if their protocol says nothing over 120 degrees, you get them to 140 and they're like, I mean, it hurts a little bit, but no problems. I don't think there's anything wrong with that. As long as you make sure the patient doesn't have like neurological things going on, they can't feel their shoulder.
I think I agree with that. Okay, so let's say a shoulder replacement done or whatever. No 120 degrees of flexion. That number is usually pretty set in stone for everybody that does it.
Yeah.
I don't think they're taking into account that everybody's different.
Yeah.
Some people are going to feel pain at 90 degrees after their shoulder is replaced, and some people aren't going to feel pain till 140, like Brand said. So
it's up to the therapist, I feel like, at their discretion. Like, if they feel like they're able to go farther than that, then go farther than that. Obviously, don't take it, to the extreme where, let's work into it, it's super painful and you're breaking the precaution, right?
Yeah.
That's different.
I think, that's why we get our doctorates. That's why we go to school, is to learn to have our clinical reasoning skills and clinical decision-making skills of, okay, what can this patient do? I think that's why we do it. I think we just kind of explained our jobs there. This was a great episode, I thought.
Yeah.
This was phenomenal. I thought we covered a lot of good things. I love my speed limit analogy. I think I might use that for the rest of my life. I might run it past a couple professors and see what they think, but I think that's pretty good.
It's pretty good.
Pretty proud of myself there. All right.
That's pretty good, yeah.
This was episode 16?
Whoa, I actually don't know.
I think it's
16, yeah.
16, yeah.
We'll see you in the next one.
Have a good one.
Have a good one. This is definitely